I am a professor in the Department of Surgery at the University of Rochester. I'm also the co-director and M.P.H of a National Cancer Institute funded research base that we have. And excuse me, that research base actually does nationwide clinical trials in cancer. And the purpose of the work in that research base is to develop new innovative therapies for treating all the side effects and toxicities that happen as a result of either having cancer or getting treatment for cancer. I'm also the co-director of the Cancer Prevention and Control Research Program for Wilmot Cancer Institute. And I direct a human performance clinical research lab that we have here in the medical center at the U of R that focuses on assessing all different kinds of human function and movement. And then we also design behavioral interventions and work with investigators who do work in the area of exercise, nutrition, cognitive behavioral therapy, touch therapy, massage. We've done a whole wide array of different things. And the work I'm going to share with you today, I'm really delighted to talk to you about some of my own personal research that I've done with yoga. My background in formal training is as an exercise physiologist and psychologist. I also have degrees in gerontology, biomechanics, and public health. So I bring a wide background of formal training to bear on my work. And my favorite work that I do is in the area of integrative therapies. And so that's why I'm going to be talking to you about yoga today. There we go. I mentioned that I am the director of a large nationwide clinical trials network that we have funded. It's the largest grant that we hold here at the University of Rochester Medical Center. It's up to about $35 million right now. And what this does is it funds the infrastructure so that scientists can actually do large nationwide clinical trials. And what's also great about this infrastructure is that it allows this clinical research to reach people all over the country and people who are being treated in small community oncology practices, not just large academic medical centers like we have here at the University of Rochester. So what you see on this map is the blue dot is us up here in Rochester, and the red dots represent community NCORs that are also funded by NCI to have infrastructure so that they can provide access to these trials for patients. And then the yellow dots represent what we call minority and underserved NCORs that actually enroll a significant proportion of patients who we don't typically see on clinical trials. And each one of these dots represents anywhere from 10 to 50 additional dots. So I didn't want to put all of that. These are like the hubs, but each of these have multiple small community oncology practices. And why that's important is it means that the results of these trials are highly generalizable to patients who come from many different geographic locations, many different SES backgrounds, cultural backgrounds. And typically these are the types of clinical trials that need to get done in order for something to actually be written into standard care and standard practice. We're pretty proud of this research base. We're one of only 2 research bases that are funded in the United States that sit in a single academic cancer or an academic cancer center. So it's a pretty great thing that we have here in Rochester. So the intervention that I'm going to be talking to you a lot about today is called Yoga for Cancer Survivors, or short, we call it YOCAS. We developed YOCAS here back in 2004. It consists of gentle hatha yoga and restorative yoga. It combines these 2 things into one class, which typically you don't always see. You might see them separated in classes, and sometimes you might see them together, but it's not common. And then we actually include all 3 of the major components of yoga, which includes the asanas, which are postures, pranayama, which are the breathing exercises, and then awareness, which are the mindfulness activities. Our intervention lasts about 4 weeks. Individuals meet in groups 2 times a week for 75 minutes, and part of the prescription encourages home practice. So we want you to do the yoga outside of these group instructor-led classes too. It's standardized because it is a yoga prescription. So we worked with a yoga consultant who was also a cancer survivor to design this. It's delivered by Yoga Alliance certified instructors. We also recently have been training yoga therapists to do this work. And we actually have yoga manuals, DVDs, thumb drives. You'll learn later that we're in the process of developing an online app to make this even more easily accessible to folks. I'll tell you a little bit about that as we get to it later. But this is really kind of what the intervention looks like in an overview. So the research I'm going to be sharing with you today is actually from 2 large nationwide clinical trials conducted in that clinical trial network I just showed you. The first study enrolled 410 cancer survivors, and we compared our yoga intervention to what is called standard survivorship care. And at the time that we implemented this study, standard survivorship care did not look like what it looks like today. We didn't have all the guidelines recommending that survivors get education, that they get standard follow-ups. It was not all of this focusing on teaching survivors about how to recover by implementing a lot of different kinds of lifestyle interventions and changes. It was basically, you would finish your treatment, everybody would celebrate and clap for you, and off you would go out the door and hope for the best. So after we finished that study and reported the results, we were fortunate enough to also get funded again to do a follow-on study where we took what we learned from our first study and we compared our yoga intervention to a formal behavioral placebo. And I'll talk to you about why that's important and what that looked like in a few minutes. And then the next thing that we did is we wanted to see if our yoga intervention was just as good as cognitive behavioral therapy for insomnia, because insomnia was the main primary outcome we were looking at in our trials, and the gold standard treatment for insomnia, believe it or not, is not actually pharmaceutical therapy, it is cognitive behavioral therapy. And then after we were finished with that, the interventions in the second trial, we were able to do some follow-up assessments and look at whether or not our benefits lasted 3 months later and 6 months later after they were done with the intervention. So these are the basic study designs. Now I want to talk to you a little bit about our behavioral placebo. So many of you are fully aware of what a placebo is when it's in a pharmaceutical trial. You have a chemical structure that you're trying to test in the form of a pill, and you put it into a pill, and then you mix it with some things that buffer it. And in a typical pharmaceutical trial, you take all those extra things that are supposed to be inert and inactive ingredients, and you create a placebo pill that looks and sounds and feels exactly like the actual pill with the agent that you believe will be helpful in it. In behavioral trials, it's a little bit more challenging to develop a placebo. You have to develop a placebo that actually looks and feels to patients as if it would help with the indication that you are testing it for. And you also want it to be matched for structure, time. You know, if it's taught in a group, you also want the behavioral placebo to be taught in a group. And so what we chose the second time around was we wanted to compare our yoga intervention to a behavioral placebo that was designed to provide the typical survivorship health education information that is required and suggested in survivorship guidelines now. And ASCO, which is the American Society for Clinical Oncology, actually puts out a manual that goes over all the different components of what it is suggested that survivors be provided with access to when they finish their treatment. Typically, It combines a didactic curriculum on a variety of survivorship health education topics, and then some peer support group. So for our particular placebo condition, our components involved reviewing with patients what their medical treatments were, reviewing what their follow-ups and surveillance should be, talking about some challenges that they might face as a survivor and some troubleshooting and ideas and ways to overcome that. We talked about side effect management and rehabilitation, and of course, healthy lifestyle and support. Some other topics that are not mentioned here, things like nutrition, financial toxicity, these were all parts of the different didactic coursework that was covered. It also lasted for 4 weeks, and it was matched exactly to the yoga group timing. They met in groups 2 times a week for 75 minutes. And then the different strategies that they learned about in the class, they were encouraged to implement these strategies in their life. We used a health education consultant to help us design this. It was delivered by people who had some type of background in community health education. And again, it's manualized and standardized. So it's a very exact and precise health education program. So some of you may know what cognitive behavioral therapy for insomnia is, but some of you might not. So cognitive behavioral therapy for insomnia is actually a classroom didactic based intervention. In its first iterations, it was done in one-on-one therapy, but then eventually they moved it to groups and found it also to be effective in groups. It covers very specific education related to good sleep and insomnia. So it educates individuals about sleep. It teaches about good sleep hygiene and how to enact stimulus control. So these are things like making sure you close all the blinds and that your room is dark and there's no lights and you don't eat in bed or watch TV in bed, or, really bed is, sleeping is one of the main activities you want to do there. We also talked about sleep restriction, which is another really important component of CBTI. And sleep restriction, what that involves is it involves basically controlling the amount of time during the day that you actually sleep. So one of the things that's important is that if you nap too much during the day, it's sometimes hard to sleep at night. And then your sleeping patterns get broken up and it can lead to insomnia, which can become chronic. So we educate individuals on this. And then we teach them skills and activities to help promote stimulus control and sleep restriction so that they are ready and able to fully sleep in the nighttime. So we also do cognitive behavioral therapy. So this is where you're led by the instructor and we talk about things that people believe and think and the way that you approach sleeping. And sometimes that involves helping people to sort of change the way that they appraise that situation or think about it. And then there's active sleep diary monitoring. So in its gold standard method, CBTI is delivered over 8 weeks, 1 time a week for 90 minutes. So we actually did it in the full-on gold standard model. And again, we use consultants and we have a lot of standardized materials to help us standardize this and well-trained instructors. So now I want to talk to you about some of what we saw with the yoga intervention. So first, in both studies, compliance and adherence to the yoga intervention was absolutely wonderful. When I started this work back in 2003, there were not yoga studios on every corner. You really didn't have access to yoga in your home very much unless you kind of already knew it and how to self-practice. So a lot of people did not believe we'd actually get cancer survivors to come in 2 times a week and attend, sessions. And we actually found that on average, they attended 6 of the 8 sessions. In addition, I believe if we had allowed makeup sessions, we probably would have gotten almost everybody to 8 sessions all the time. But given the way we were implementing this, we did not allow makeup sessions. So 86% of the participants attended 5 or more of those classes. And if you are familiar with attendance rates for people who join yoga studios or join fitness clubs, getting people to attend that number of 8 sessions is hard to do in healthy individuals who are not experiencing cancer, let alone in patients who have just, completed treatment and are suffering from side effects and toxicities like insomnia. In our second study, we actually also were able to find that fewer participants withdrew from the yoga intervention compared to the other 2 arms. So the survivorship health education placebo condition and the cognitive behavioral therapy for insomnia condition. This is important because one of the things that happens with CBTI is that it's, number one, it's very hard to find people who are actually trained to deliver CBTI. It's often not covered by insurance. There's usually a cost to it. And often more than attending a yoga session that might be offered at your local YMCA or Jewish Community Center or a yoga studio. And people report that they don't like it and it's very hard for them to adhere to. So if you think about when you were transitioning off your treatments, one of the things that they're going to tell you to do in CBTI is when you're tired, they don't want you to take a nap for longer than about 15, 20 minutes. And I'm sure you all probably had many days where you needed to sleep during the day for longer than 15 or 20 minutes, or at least felt like you had to. Also maintaining the daily diaries and a bunch of other stuff that you have to do, people often report that it's not so easy. And so people frequently either don't do it and approach it, or they withdraw and drop out after they do it. So finding something like yoga that can also work and be just as good as cognitive behavioral therapy would be really good, especially given that most people do find attending the kinds of yoga classes that we were studying enjoyable and actually very easy and accessible to do. All of the survivors that report that participated in the yoga found it useful in some way for helping with insomnia and would recommend it to other cancer survivors. And that's also a caveat that we really put a lot of faith in, is because if something works but patients won't do it or they don't like it, it really isn't that useful to them. So in our study, the primary outcome that we were funded to look at was insomnia. And so here I've combined the insomnia outcomes off of both trials. And in the first trial, we learned that the yoga participants improved their sleep quality. They increased their daytime sleeping, or decreased their daytime sleepiness, and they actually reduced their sleep medication use. All significantly greater than what we saw in the people who were in the standard care control condition. And in fact, in that first study, one of the things that was a really big finding is that the individuals in the standard care control, they actually upped and increased their medication during the 4 weeks, but their sleep still did not improve as great as those that were doing yoga and simultaneously lowered their sleep medication usage. So it was a really big deal. There were lots of press releases about that finding all over the world. I was actually really surprised that finding was stronger than I even anticipated it would be. So you can imagine, as a young junior scientist, I was doing triple backflips in my office the day that we analyzed that data. So in the second study, we looked at the effect of yoga for improving insomnia compared to the placebo that I told you about, the survivorship health education. And what we found is that our yoga actually significantly reduced insomnia, much better than the survivorship health education program at all 3 time points. So immediately post-intervention, 3 months later, we see it's still, yoga is doing much better, and 6 months later, yoga is doing much better than just a general survivorship health education program. And we would kind of expect that, because we would expect that survivorship health education is not targeting sleep. But oftentimes, I also think that people think if patients go through these general survivorship health education programs, all their side effects and toxicities in some ways should kind of right themselves and sort of get better. Well, they get better, but they don't necessarily get better fast and quick and to the same degree as if you actually pay attention to a particular side effect that's bothering a patient and target that side effect, right? And so that's what we see here with the yoga. So typically, when you do a randomized clinical trial, you look to compare one thing to something else to see if it's better. But in this situation with the cognitive behavioral therapy intervention, what we wanted to see was it would be great if yoga is better. But what if it's not better? What if it's equal to? What if it's just a little bit less, but not significantly less, so the differences between the two really don't amount to anything? If that came out to be true, that maybe it's better, but even if it's not better, it's basically equivalent to CBTI. And what that means is patients would have a choice. They'd have a second option that they could use that's a non-pharmacologic behavioral intervention that they could use to treat their insomnia. So what we did, and I always like to explain this to people, for this second hypothesis that we tested something called non-inferiority. And I'll just give you a rundown of what that means. So you have to a priori, so that means before you start this trial, you have to define what your non-inferiority margin is. In other words, what kind of difference can there be between yoga and CBTI, where yoga may be a little bit less, in terms of outcome on sleep, but still be considered equivalent. And so we do all this with some fancy mathematical modeling that I'm not going to necessarily go into. But what we decided is that as long as there was not a 1.15 point difference in insomnia on the scale that we use to measure insomnia, so basically a 1 point difference, if there wasn't less than a 1 point difference, then we were going to say they're basically the same in terms of outcome. You have to blind the participants so that they don't know for sure typically what they're getting, if you think about it in terms of a pill on a pharmaceutical trial. But in a behavioral intervention trial, you design the behavioral interventions so that it's believable that both interventions could potentially help you with your sleep. Knowing that one of them probably, or hypothesizing, really, if we knew it, we wouldn't be doing the study, but hypothesizing that one of them really won't affect the sleep. And so in a behavioral trial, you don't blind by using a pill or something, but you blind them to the hypotheses. So you don't upfront tell them, we believe yoga is going to be better, right? Or we believe CBTI is going to be better, or whatever your hypothesis is. And so they enroll, and of course they're going to know if they're in yoga or health education or CBTI. They just don't know which one is actually really designed to help with their sleep. At the end of the study, obviously, you also debrief them, just like you would unblind a study in a patient in a pharmaceutical trial. So then you have to do two things. You actually have to analyze your data using what we call intent to treat. So everybody gets analyzed that enrolls in that study. They're analyzed in the arm they were assigned to, regardless of whether they do yoga or not, regardless of whether they do your CBTI or not. You analyze everybody. And then the second analysis you have to do is you analyze only the people in those two arms who actually got the full prescription that you prescribed. So in our case, that means the second one would analyze people who didn't go to all 8, or who only went to all 8 sessions for both the yoga and the CBTI. And in order for something to be considered to be non-inferior or inferior, as the case could be, both of these analyses have to concur and give you the same conclusion. And then you graph it and you plot it and you look at the mean with the 95% confidence interval, and you look at where these lines go and whether they overlap and how they overlap with this red line and with the 0. So here you can see if it's all the way to the left of the 0, then yoga, for example, would be superior to CBTI. If any portion of the line actually overlaps the 0 or kind of lands in this middle range here, it would be considered non-inferior. And then there's 3 lines that will show you that it's inconclusive. So these 3 lines, the tail is going to the right of the red non-inferiority margin. And then lastly, if it's all the way to the right, it's inferior. So what did we find? So if you look here at the lines with the blue diamond, recommend the intent to treat or represent the intent to treat. Remember, that's all the patients, whether they did the yoga or not, whether they did the CBTI or not, this is what it looks like. And so you'll notice that all of these with the blue dots, they're all the way to the right of the red line. So this would suggest, with just the intent to treat, the conclusion would be that it is not, that yoga is in fact inferior to cognitive behavioral therapy for insomnia. But then when we look at the yellow dots and the lines with the yellow dots, now this is the people who actually did the full prescription. So that means they went to all 8 yoga sessions, they went to all 8 CBTI sessions. So in here, the tail to the left is crossing that red line. And so that leaves us in a situation that gives us a different conclusion than the intent to treat analysis. That conclusion with the per protocol analysis would suggest that the results are inconclusive. And we can't actually say that yoga is better or worse or even equivalent. We really have no idea based on this what we can conclude. So in terms of where we landed with our interpretation about what this actually means, you also have to take into account all the data that's present on the yoga. So the first trial that shows that doing yoga is better than doing nothing. This trial, which shows yoga is better than doing a survivorship health education program. And now we see that the results are inconclusive regarding CBTI, but we have one other caveat that we have to consider that's very important, and that is the fact that we had a significant proportion of the people in the CBTI group drop out of the CBTI and not finish it because it was so hard. So at the end of the day, and our interpretation of this data, and we've run this by many colleagues across the country, are that we still recommend yoga actually for treating insomnia for cancer survivors. It is effective, it's better than nothing, and it's better than a behavioral placebo or general survivorship health education. And we suggest that clinicians offer patients who are suffering from insomnia both of these options. So in other words, you could use yoga for treating your insomnia, or you could use CBTI for treating your insomnia. And really, the one that is the best one for you to use, that you will get the best effect out of, will be the one that you like and the one that you will do. It's also noteworthy to note that all the effects that we got with the yoga were in half the time that we got it with the CBTI. It only took 4 weeks instead of 8. So when you think about how quickly you want to see results and what you want to get and which one you might enjoy doing more, you could pick either one of those, and you could rest assured that at the end of your 8 sessions, you would see some improvement in your insomnia. So that's the story with insomnia. Yoga has many, many other stories based on our data and the work that we've done in our group. It's also one of the reasons why I like it so much. And cognitive behavioral therapy doesn't necessarily have the same benefits among all these other toxicities that I'm about to show you. So here we go. So we also found in our work that yoga, our yoga intervention, significantly reduces fatigue by 41%. While if you look at the standard care individuals, their fatigue did go down. So it did recover some for them after they were done with treatment. But if you look at that data, if you do yoga in 4 weeks, you're going to have almost 4 times the magnitude of reduction in your fatigue than you would if you just waited for it to resolve on its own, right? And it may not. So we don't know what goes on with that with other individuals as they tail goes on out, whether it continues to get better or it hits, because we weren't able to follow that group of individuals that far. So yoga has tremendous benefits in fatigue, and we published these these data. They're out there, and actually yoga is actually recommended in the standard care guidelines for treating fatigues these days. So a lot of times people think that if you fix your sleep, you'll fix your fatigue. And so we were interested in trying to see what this relationship might look like in our data. So one of my junior faculty members, Dr. Lynn, she took this data and she analyzed, she did what we call a mediational analysis. So she looked at how, and what she wanted to know is, if I improve sleep, how much of that improvement in sleep is explaining the improvement I see in fatigue? And what we found in our data is that 22 to 37% of the effect that yoga has on fatigue is explained and contributed by improving 2 things: overall sleep quality and daytime napping. Now, the 22% goes with the sleep quality and the 37% goes with the daytime napping. And this was really intriguing to us because we thought, wow, okay, we expected to see the sleep quality piece, but we did not understand what was going on with the daytime napping, because we didn't have them do the yoga at any particular time of the day. We didn't tell them not to nap. And so we were like, wow, this is really interesting. So we went back and looked at our data to see when most of our sites around the country actually chose to teach the yoga, what time of day. By and large, it was always taught somewhere between 5 and about 6 or 6:30 in the evening. So most commonly when people would be getting done with their day or off work and they would come to yoga class. And at no point did we tell people, you know, in that group, don't nap. But what we also realized, we were able to look at something else, which I'll talk to you about later. We were able to plot individuals' circadian rhythm patterns in the study. And what we found in the yoga group is that they also had a more normalized circadian rhythm. And we think that what was happening with that normalized circadian rhythm is that they weren't feeling as sleepy during the day. And you can see in that rhythm, they were getting up earlier in the morning at more normal times, like, 7, 8 o'clock. They were going through their day and they were going to bed at more typically normal times, just by infusing the yoga into their day. 1 75-minute class 2 times a week. And it was really stunning to us when we could actually take a look at some of this mechanisms and how it might actually be working. And that happened without us ever asking them not to take naps, which is one of the key things that they do ask you to do in cognitive behavioral therapy. But we did not even actually have to ask for it with the yoga. It just kind of happened. We also found that yoga improves individuals' ability to do some typical activities of daily living, like basic walking. There were significant improvements in people reporting their ability to just get up and walk and move around throughout their day and do what they needed to do. They also significantly improved their overall general physical activity. So this can include things like walking, maybe going to the gym, but also doing house chores, working in the garden, things like that that were challenging for them to do. And then overall quality of life. So again, because fatigue is such a prominent toxicity that's often quite debilitating for people and very frustrating at times, we were interested in the relationships between, if we improve fatigue, how much of that improvement, how much is that impacting this individual's overall quality of life and what they report. And we actually found in this data, again, Dr. Lin did these analyses, that 45% of the effect on quality of life is contributed by improving fatigue. So if you take a look at improving sleep, which really has a big impact on fatigue, and fatigue, which can have a really big impact on quality of life, these results are actually pretty astounding. They're bigger in terms of percent gains than any drug that's been tested and any pharmaceutical that's been tested for improvements in sleep or fatigue. So it's really pretty powerful data. So a few more things that we found. We also found that the yoga significantly improved both anxiety and mood compared to our standard care and our control conditions. Big reductions, 18% versus just 4% if you just kind of waited for your anxiety to reside after treatment. In terms of mood, a 45% reduction in negative mood and mood disturbance, with only 11% reduction if you kind of really didn't do much to take care of it. We found, so another one of my junior faculty actually looked at the subset of only breast cancer patients that were on this trial, and he wanted to look at the ones who were taking aromatase inhibitors and tamoxifen because of the pain and arthralgias and stuff that happened. And there was a significant reduction in pain, overall pain, in women who were taking aromatase inhibitors who were breast cancer survivors. And we didn't reach statistical significance for those in tamoxifen, but we think that had to do with the sample size. But as you can see, there was a much bigger drop in pain in those on tamoxifen in the yoga group compared to the control group. We see a very similar profile here with muscle aches in terms of those on aromatase inhibitors, and then a statistical trend for those on tamoxifen. Many people are talking about something that we call chemo brain, or some of the memory difficulties and cognitive difficulties that patients experience. And we can see here that there was a significant reduction in memory difficulty in the yoga group compared to the control. So those in the yoga group found it much easier to remember things and had that sort of regain that cognitive capacity pretty quickly. I mentioned to you before that we also found that yoga regulated circadian rhythm profiles. And one of the things I want to mention here is that with the yoga regulating circadian rhythm profiles, it's pretty remarkable too, because ultimately, and we haven't been able to study all of this yet, but we're actually doing some work in this in one of my current studies, is if we are able to regulate a person's circadian rhythm, we are going to be able ultimately to have impact on things like cell regeneration, hormone expression, cortisol expression. Obviously, you know that it has an impact on these behaviors, right? Like hunger and eating and sleep activity, behavioral profiles. And ultimately, that's going to have an effect on lots of other things, hopefully in a healthy manner throughout your entire physiological systems. So overall, when we take a look at what we learned from these two trials, we found that yoga is great for improving sleep quality, insomnia, reducing sleep medication use, fatigue, walking, physical activity, quality of life, anxiety, mood, muscle aches, pain, memory, and circadian rhythm. I venture to say if this was a little itty bitty pill that we could all just take once a day, we'd all be running to the store and clamoring to take it, right? But one of the challenges with yoga is you have to actually do it, right? And historically, you have to go different places to do it, to a studio or a gym. You have to have some equipment. It's not always easily accessible to those in lower SES brackets, not always easily accessible to those who live rurally. There's some cultural beliefs that sometimes challenge people, that they feel like there's some spiritual conflicts in terms of participating in a yoga class. And so the work that we're doing now and some of the trials that we're doing is to further elucidate some of these mechanisms, but also to increase the reach and to create versions of this yoga intervention that are much more culturally accepted across a wide variety of cultures. So based on what we've learned, this is what we recommend at this point. So we stick pretty tightly to our yoga prescription. It's pretty similar to other yoga studies that you may have seen published. But we really only recommend gentle hatha yoga or restorative yoga. Our intervention combined both of these into one class, but you could do either just a gentle hatha or just a restorative yoga class, and you could alternate them a little bit and still probably get similar benefits. We suggest that you do a version of yoga that actually includes asanas, breathing, and mindfulness. And this is really, really important that you work with an instructor and you attend a class where the instructor pays a lot of attention to teaching the postures, but also modifying them so that they're doable by individuals, no matter what limitations you may have regarding your body. And that the breathing and the mindfulness is integrated in at the same time that you're doing the postures. So it's not like you sit in class and you do some breathing exercises and then you get in, you do a bunch of chaturangas and you feel like you're just doing push-ups as fast as you can in yoga class. And then at the end of it, you lay down in your shavasana and you go, oh, this feels good. Now I'm going to be mindful. That's not really the way it works. You really have to combine these things and integrate them together into a class. And that takes a very skillful instructor. The dose is 60 to 75 minutes based on what we actually saw in our patients. And the majority of our patients did at least one other day at home. So we can't negate the fact that that extra day during the week adds up. And so really, we would suggest at least 2 face-to-face sessions, but with at least 1 more at home during the week. And obviously, our gentle hatha and restorative, this is not vigorous yoga, okay? This is not hot yoga. It's not Bikram yoga. It's not vinyasa flow. It's not heated vinyasa flow. It's a very low to moderate type of yoga. So if you are going to go down the street, for example, in Rochester, we have breathe yoga. If you were going to go to breathe, you could take a restorative class. You could take a yin class. You could take a foundations class, right? You could probably even take a basic vinyasa class. Those all include the hatha yoga components or restorative type components. But you would not want to take, we can't guarantee that you're going to have the same kind of effects with other classes that you might see out there in town. And I don't want to just promote breathe. There's lots of other yoga studios around town. There's yoga at most of the fitness centers in town. But, I'll talk a little bit later about what to look for in terms of instructors. But you're really looking for that gentle, easy, low to moderate yoga. This is not something that is super strenuous or, really, really challenging to do. When we talk to medical providers and cancer survivors, we tell our providers to provide information regarding the benefits of yoga for managing toxicities to their patients. We also encourage them to become very knowledgeable of what's available in their area to actually recommend for their patients to be able to go to. It's not just recommending a yoga studio, but it's also recommending a yoga instructor that has special training to work with cancer survivors who understand some of the unique needs that are experienced by survivors, and have have that kind of repertoire in their background to really successfully work with patients or survivors. And then to survivors, really, we strongly encourage just saying yes to yoga, but it's also really important to choose wisely. You hear this a lot when it comes to exercise. Many people think that exercise is something that everybody should do and you don't have to worry about it. But actually, you can hurt yourself. You can hurt yourself with any kind of exercise. And you really want to choose wisely. You want to start super gently, progress very, very slow. And I would say very, 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 very slow, slower than you probably can imagine. And practice very safely. And you really want to work with a qualified yoga instructor. Don't be afraid to have a conversation with your doctor. Most of the doctors at Wilmot will talk to you at any of our locations. If you ask them, hey, do I have anything I have to worry about? Moving my arms, my legs, my muscles, anything other things I have to worry about, my heart, my pulmonary system, and they will be able to give you some ideas of things to either watch out for or not. And the other thing I want to mention is never, never, never be embarrassed to use props and make modifications for a safe and effective yoga practice. That's perhaps one of the things that even people who are not survivors of cancer have a hard time doing. If you ever watch me in a yoga class, I use all kinds of props, okay? I always have my blocks. I'm rarely putting my hands all the way down on the floor. I frequently will do things like you see in the picture there where I'm in a restorative pose and I'll use a chair, or they say to get a bolster and I get 3 because I want my feet higher in the air, right? So that's one of the things I love about restorative yoga is it uses a lot of props. It teaches you how to use those props and feel comfortable with them. And so always make sure that you're making modifications, and you want a really good instructor who can help you make modifications, because for every single posture that's done in yoga, there are at least 1,000 modifications, if not more. And we have to have that because every single person's body is unique, and your body's even more unique after you have gone through cancer. Whoops. So what are we doing now? So here's where we're going with this. I'm working on developing an app that, we started out developing the app so that we could actually put all of our content into the app up on a smart device. So instead of having to come to class, people could actually use the app and access it. We got away from old paper manuals, and nobody seems to have DVD players that much anymore. So it's all on smart device. And so the other thing that we realized is while we were busy working really hard with our talented programmers in Israel, that we, myself included, I could not read everything on my smartphone. And when I wanted to do the yoga or watch it, I'm trying to put my glasses on to see, and it just wasn't working. So what we've done now is we've taken what we've created with the app. And so we actually have a way that you can put the app on a regular computer screen. So a regular size computer screen, if you like that, a tablet or a laptop. And here comes the best part. We have a way that you can get it up onto your big screen TV in your home. You can follow all the videos. You can follow all the materials and things like that. We are about to launch our beta version of testing that, and when we launch the beta version, we're going to find all the places that we have to fix technically. But it's taken us almost 2 years to get to this point of creating this app. It was really detailed and a lot of work went into it. I'm also working with a very, very talented molecular geneticist, and his name is Dr. Altman. And what we are seeing in data that he just presented, so we're following up on this circadian regulation hypothesis and data that we saw. And what we're actually just presented in Dr. Altman's data from this trial is that yoga is actually changing the gene expression of your circadian clock genes. And I am so excited for us to publish this data because there is no one, absolutely no one in the world that has this data or has these results except for us. And I do believe we're going to be one of the first people to show that yoga can actually change your gene expression in cancer survivors. And that by changing these circadian clock gene expression, this is one of the ways that we're able to regulate the circadian clock in an individual. And if we regulate the circadian clock, again, remember, I showed you way back on this PowerPoint, right up here in the right-hand corner, cell regeneration, hormone secretion, cortisol, everything all the way down to your heartbeat and the sinus rhythm of your heartbeat, right? Because that's an automatic circadian rhythmic pattern. And it's going to be pretty doggone powerful if we actually, if we show this and then we're able to replicate it. I think I'll be done with my career at that point. I'll be satisfied. So it's pretty exciting what we're doing with gene expression. And then the last part, I'm very excited about the fact that I was able to partner with some colleagues here in Rochester at the medical center, but also out in the community. I mentioned that there's sometimes cultural clashes where people don't necessarily feel like they can participate in yoga because they worry about it sort of clashing with their belief systems. And one of the communities that in all the yoga trials you'll ever see published, you rarely will see a large proportion of Black cancer survivors and participating. And I know this from my work over the years that a lot of Black cancer survivors are fearful of participating because they feel like it conflicts with their spiritual beliefs. It's probably one of the number one things. Number two is that when you think about yoga and you think about typical Black bodies, they're not always the lean and mean and clean bodies that you see in all the yoga pictures. Most cancer survivors do not have those types of bodies. And so we're going to be working really hard to take what we've done with Yogas and to culturally transcreate it so that it fits within the Black culture. It addresses some of the spirituality questions and issues that arise. And also, I mean, it may seem simple, but when you go out and you look across the country at all these different yoga programs, you rarely see Black yoga instructors. You rarely see a class full of, 90% individuals of color participating. And so we were able to apply for something called a HEAL grant. And really, HEAL is focused on reducing pain and developing new interventions for treating pain. It's set aside money that came out of NIH because of the opioid epidemic and the opioid crisis that we have. But recently they said, we want you to focus on treating pain in a population that also has another chronic illness condition that, really the pain is stemming from. And so I jumped up and I was like, we already have data to show that the yoga works for this. They wanted it also to be in underrepresented individuals. And I was like, it was a perfect chance for us to take this and do something here in Rochester. So we're going to get 2 years of funding. If we do get this grant, we'll have 2 years of funding to recreate this, to do a lot of focus groups, to build a lot of relationships in the community, train a whole cadre of Black yoga instructors that can teach at a lot of the faith-based organizations throughout our community. And then the last 3 years of the grant, we will actually do a small clinical trial. So that is where we are. I would be remiss if I did not thank everyone who takes part in doing this work. It takes a village. And probably the most important on this list are the participants who participated in these trials, because without their time and effort and energy, we would never learn anything.